mentioned was gout is mostly a foreign body that's sort of accumulating within the joint lines. And the reason for those, or that foreign body, is MSU crystals, meaning too much uric acid in the body. As the slides progressed, we kind of determined that, hey, was the uric acid being caused by too much uric acid intake, or if there was a blockage that was causing enough uric acid to leave? Either kidneys were the problem, there was an obstruction, or you were getting too much uric acid. We went through some of the risk factors, and then most importantly, we spoke about the treatment options. We spoke about giving NSAIDs like indomethacin. We also spoke about colchicine. And then last but not least, we spoke about chronic patients who get a medication called allopurinol. Okay, so now that we know a little bit about gout, and we had also said that it's the crystal that you see within under the microscope are negatively charged crystals, and they kind of shine, right? So now the next question comes into place is, well, how is gout and pseudo-gout different? Well, the boards will try to trick you in the sense that as these slides progress, you're going to see that pseudo-gout pretty much has the same signs and symptoms, meaning joint pain. Now, how do we determine that joint pain changes slightly? So let's get into it. We had indicated that gout is caused by MSU crystals, and it causes the foreign body to start getting pretty accumulated within the joint lines. Well, once again, the same thing happens here, but in this case, it is not MSU crystals, meaning too much uric acid in the body. Instead, it's calcium deposit crystals. So instead of uric acid or MSU crystals, here we have calcium crystals that start depositing within the joint line. Now, if you're sitting and you're starting to start thinking clinically, it should make sense. You should say, you know what? Now I see, in the sense that patients sometimes have what? Kidney stones that happen. Those kidney stones have to be evaluated. Those kidney stones by urologists or nephrologists, what they'll do is they'll look at these kidney stones and will say, whoa, this is a calcium-based kidney stone. Therefore, the patient has too much calcium in his body or her body. There's a good chance that calcium that's floating around the body will also start to participate within the joint lines, causing pseudo-gout. You get the idea? So once again, pseudo-gout presents the same as gout, meaning joint pain will be there. So the case vignettes that you see on your boards are going to describe, hey, patient comes in, complaining of joint pain, and so forth and so forth. But if you do remember our previous class, we had mentioned that gout, and most, I think about 85% of the questions that you guys will get on gout will indicate somebody having pain in their great toe, right? Well, here it's different. You're not going to see it within the toes. If it's the toes that they're speaking about, the case vignette will lean towards gout. We start talking about pseudo-gout, we're talking about different areas, and you'll see what I'm talking about in a second. Right now, as we had mentioned before in the previous slide, the problem here is too much calcium built up within the joint line. At times, patients are asymptomatic. It's a slow deposit, but over time, it really starts to accumulate, and then you have that foreign body sitting between the two joint lines, and then as you're moving the joint so much, the pain really starts to come in place, okay? So what happens? Joint pain, stiffness, and things of that nature. So the next question comes into place is, well, do we need to know much epidemiology? Is it that prominent? Do we see it in a lot of patients? The truth is we do. This is a disease primarily seen in the elderly, usually between the 65th, the 75th, at the age level. Therefore, your case vignettes are going to say 68-year-old, 70-year-old, male, female, etc. When it starts becoming chronic, we tend to see it in females. And once again, there is a strong genetic component here. Meaning if your family has it, there's a good chance that you have it. Your mom and dad has it, there's a good chance that you'll have it. Bless you.
Thank you.
So what are the risk factors? Well, the risk factors are aligned with gout. If you think about it, trauma, you break an extremity, that cortex of the bone is broken, and you have calcium floating around your body too much, that calcium will start accumulating within that joint line, and there you go. Hyperparathyroid, hypercalcemia, all those are indicators that they'll precipitate more calcium to be deposited within the body. Now you might say, well, what do you mean? How is hyperparathyroidism? Well, we all know. Remember, it's a perfect example. Somebody goes in for thyroid surgery, and a surgeon accidentally nicks the parathyroid glands, now all of a sudden all the calcium that's usually within the bones starts coming outside of the bone. And this is how you start having. Or you just taking too much calcium. Way too much calcium. Okay? Now, you will have an inflammatory response, therefore you're going to have a lot of inflammation. And when that inflammation kicks in, that's when the pain really, really starts. Now, exactly where do you tend to see it mostly? You will see most of the case vignettes will tell you that it's happening within the knees. Because the incidence are much, much higher. You can't see in other joint lines, that's fine, but much of the case vignettes that you will see, and they're leaning more towards pseudogout, they're going to tell you that, hey, this is a 68-year-old male, 70-year-old male, comes into your office complaining of bilateral knee joint, denies any mechanism of injury, denies any fall, and so forth and so forth. Then all of a sudden they'll start giving you lab values, and lab values might show calciums that are really, really elevated. Guys, do me a favor, put your phones away, just for like 20 minutes, half an hour, put your phones away. Okay? So please keep that in mind. Okay? So, next question I have for you is, well, once again, how do you differentiate between gout and pseudogout? We had mentioned that one is calcium and one is what? MSU crystal. Then the next thing that you need to know, especially for the boards, because they might ask you this, pseudogout has positive polarized crystals. On the other hand, gout is negative polarized crystals. When I took my recertification, it was a very simple question. They said, hey, patient was found to have positive polarized crystals. They're like, that's easy. Pseudogout, boom, we move along. I looked at the labs showed the patient had high levels of calcium, and we were off to the races. It was pretty straightforward and simple. Now, let's go back to gout. MSU crystals start forming within the joint lines. Well, we had said that x-rays might not be the best thing to do. We had said to get uric acid levels. Uric acid levels will tell us if the problem is uric acid, which it is. Here, what you would normally do is you get calcium levels, and you could get that. Calcium levels might be elevated, but guess what really, really gives away? An x-ray. Because calcium, once it starts depositing within joint lines, it's very, very visible. And here's a perfect example. Notice how these joint lines are nice and clean. The cortex is perfect. There's nothing wrong with the cortex. It's not broken. The one above it looks like it's perfectly fine also. But then all of a sudden you see this foreign body start setting in. Foreign bodies starting to set in. And that's how you can say, oh yeah, there's nothing wrong with a joint. You just have these foreign bodies that are sitting in there. Oh, I look at the calcium levels. Calcium levels are elevated. Oh, they're having joint pain. Oh, and then the case vignette also said some positive polarized crystal. This has to be pseudogout. Sorry? Yeah, so here, you see this foreign body right here within the joint lines? So the cortex here is nice and clean. The cortex here is nice and clean. Nice and clean. There's no breakage in the cortex. Same thing here. The cortex is clean, but then this foreign body starts setting in. That's calcium still. That's calcium still. So how do we treat these? Well, the problem is not that, hey, the uric acid built up. No, no, no. Here, NSAIDs, non-steroidal anti-inflammatory drugs. Joint aspiration. Go ahead and put a needle in there, take some of that calcium out and send it to the lab. They'll let you know. And then once again, steroids. Steroid injections will help. But giving someone systemic steroids like prednisone and so forth for a short period of time might be ideal. But a long period of time, it's going to do no use. The calcium's still going to be there. You get colchicine, which is the same medication that we use, that inhibits or brings down inflammation in the body, so that would be warranted. But what would be warranted, what you should not do is you do not give allopurinol to patients who have pseudogout. Makes no sense to do that because the problem is calcium. It's not uric acid. We're not trying to get the kidneys to push out the uric acid. The problem here is calcium that's built up. Now the question comes into place is, if there's too much calcium in the body, what is the reason? Well, maybe too much calcium being taken in. But on the other hand, you gotta be very, very careful. Too much calcium floating around the patient's body, you also have to do a full workup. Because calcium at times could be a sign of malignancy. Now, what kind of malignancy? Hard to determine. Could be anything. Or you should also work the patient up to make sure the patient does not have any what? Kidney problems, kidney stone, etc. Gotta keep it close. It's a workup. Now, if you were to go ahead and get a basic metabolic panel of someone, what's the first thing that you would look for? What's the 3 things that you would look for on a basic metabolic panel or comprehensive metabolic panel? Anyone? What's that? Calcium, number 1. What else? Sodium, okay. What's that? Calcium, okay. What else?
Creatinine.
But calcium is number 1. What else? Creatinine and what else? Fine. Those are 3 things that you have to pay attention to. Because the problem is if the kidneys not pushing the calcium out, or the problem is the patient have a kidney stone and it's a calcium kidney stone and that's blocking the ureters and so forth, and all the calcium is not excreting, or you're just making way too much calcium and just binding together and causing tons and tons of kidney stones. Now, usually the first sign that this calcium, too much calcium is putting your body's holding on too much calcium is if you start having kidney stones. Okay? And it's very easy. Get kidney stones, not a problem at all. Let's do a workup. Let's see what the calcium levels are. Let's see what the BU and creatinine. Is it the kidneys that are causing the problem, or is it just too much calcium? You have to evaluate the patient. Yes. Absolutely, that would be the further workup. Yeah. And you would see the patient had any recent surgery that did not, and then calcium levels are elevated, then you have to start saying, well, where's calcium coming from? And then even if you get an x-ray, right? It's a great question you bring up. So what you'll see is this. When you see an x-ray, and when you review the x-ray, look at the x-ray, and there's not enough calcium and vitamin D in the bones, right? What might you see? What's that? Well, actually, people, what will a bone look like if there's not enough what? Pores. Representing what? Osteoporosis. Get the idea? So it's a working diagnosis, and what we want you guys to do is start thinking outside of the box. At this point, you should start thinking clinically because a lot of things start opening up. And that's the way medicine is. You get an x-ray, you just see this and that's fine. But here, the bone looks like it's nice and clean and healthy, then you know that's not the problem. But all of a sudden you see this here, and the bones look like crap, osteoporosis, and then maybe it's a vitamin deficiency, etc. All right, we're good with that. Remember, the key points are very, very important. The key points are, remember, the positive crystals. The signs and symptoms are the same. Calcium is the issue. And then x-rays, etc. All right, let's move along to other neuropathies. Once again, when we say neuropathies, what are we talking about? We're talking about joint pain within the body. Well, if there's joint pain, then where's the pain coming from? It's either bacterial or viral in this situation. So let's talk about some bacterial etiologies that cause joint pain within the body. All right, let's talk about some overall, I guess, information that would make sense as we move along towards this. We know that when you have bacteria that accumulates within the joint line, it's a problem. Direct inoculation or secondary, we see the problem comes into places, sometimes surgery, trauma. You might say, what do you mean trauma? Riding a motorcycle at 75 miles an hour, wasn't looking, guy falls off a motorcycle. By the time everything settles in, 4 joints are broken, shoulders hanging off, and then just blood and debris from the road all within the joint lines. That's the kind of trauma I'm talking about. Or a very simple trauma. A few years ago, and I always speak about this because it makes perfect sense and patients tend to remember it. Do you ever get those shoes called Heelys? I think they were Heelys. Kids have them, and there was wheels in the bottom. Well, my daughter wanted them like a couple of months ago, and I said, no, we're done with that. It's all over. I'm like, it's not even popular anymore. Nobody likes it. She's like, yes, they are. I'm like, no, they're not. Cool kids don't have them, and that was getting me. But anyhow, I used to do a lot of work in the ER, and kids, when this very popular, kids used to take those and they would wheel, and then they couldn't stop, they would fall back, and their elbows would hit the floor. When the elbows would hit the floor, it would shatter the elbow, scratches, and then all the dirt would go right within the joint lines and trap. You kind of get the idea how trauma and surgery and things of that kind of make sense. Surgery is you're making incisions, and all of a sudden the instruments are not clean, and you're introducing a bacteria within the joint line that will cause it. It happens once in a while. There's all other kinds of reasons. IV drug abusers, we tend to see this a lot in. That immunocompromised patients who have HIV, have AIDS status, and their body's just not strong enough. Well, bacteria, once it gets into the body, whichever way it might be, will travel wherever it needs to travel. So it makes sense. All these risk factors do make sense. Okay? Next question comes into place. Well, how do you evaluate these patients? Well, everyone's different. You have a little 9-year-old that comes in who fell off their shoes with the Heelys, somebody with a trauma, IV drug abusers. Well, how will they present? Well, history and physical is key. Listen to what they tell you, and that will make sense. That's the reason why I'm giving you these examples, the Heelys and so forth. Lab exams we'll get to. Joint aspirations make sense, but you will have a patient comes in having joint pain, number one, fever, chills. And the risk factors that we spoke about in the previous slide have to align with that. And then on the physical examination, once you have the history out of the way, the physical examination is key. As you inspect that joint, because it's usually unilateral. Very rarely will you have someone having both elbows having bacterial arthritis in it. Okay, you will see a lot of IV drug users have it. What they'll do is they'll start taking needles and start putting it between their finger, between their toes, and things of that nature. That's what we can see a lot of. So when these people came in, or these patients came in, I apologize, not people. When these patients came in, unilateral joint erythema. That's usually the first sign that you will see on a case vignette. Erythema, hot, tenderness within that joint line. Patient might have a fever. All right, so now I have the history out of the way, the physical exam out of the way. Heat, fever. All right, so now that I have this patient in front of me, I need to confirm the patient has bacterial arthritis, meaning bacteria has implanted within the joint line. Well, how will I find that out? Well, number of things you can do. One is you can get a blood test. You can go ahead and put a needle in there, aspirate everything out, send it down to the lab, and the lab will send you some results back saying, oh, we received that aspiration that you kind of collected from the joint line. And within that specimen, we see certain things. We see the specimen is purely. When we checked it out, it had elevated white blood cell count. We also found that the specimen has decreased sugar levels. Now, this should kind of make sense on its own if you start thinking clinically. We're talking about a bacterial agent here. So bacteria likes what? Sugar. It's like a bug. Bugs like sugar. They need sugar to survive. They need sugar to what? Replicate. So if all of a sudden you get a specimen, the sugar levels are going down, problem is it's a bacterial agent. Same thing applies for meningitis. Viral meningitis to bacterial meningitis. We have to know the difference because we treat them differently. If it's bacterial meningitis, patients getting IV, staying at the hospital for days, maybe even a month. If it's viral meningitis, what do? Send them home. We keep them overnight, control the temperature, and say go home, and it'll go away on its own. Yes.
If someone had like cellulitis like on a joint, would that all be positive too?
So it wouldn't get to this point because if you have cellulitis on your skin, right? So your skin is an organ; it keeps it out. But the minute it starts penetrating through that skin and it starts traveling to the joint, that's when you have bacterial arthritis, and this is when things really start happening. Because the minute your white count starts going up and your sugar levels going down, that means it's what? Septic. It's gone into your bloodstream. And that's a whole different scenario than someone having just regular cellulitis. Okay. Cultures are usually positive. You get blood culture, that means it's starting to circulate everywhere in the body. Now, I put something up here for you guys to kind of get an indication of what I'm speaking about. You have to start taking evidence-based medicine into practice. It's so important you do that. Now you're saying that, hey, blood cultures are usually positive. But then why are you telling me only 50% of them are? Shouldn't it be 100%? Well, yeah. But we found from evidence-based medicine that by the time you're having joint pain, it's swollen, it's hot, you have a fever, you end up at the hospital, only 50% of them are completely septic. But let's say if you wait, like I have no ride, I have to stick it out for another 3, 4 more days, 5 more days, 7 more days. By the time you get to the hospital, then you're completely to a point where it has been treated. Then those numbers go up. Question comes in place, how toxic are you? Our evidence has showed us that once it starts becoming painful, it's hot, and so forth, it's usually about 50 times. After that, it's a bigger problem. You start hitting 75%, of patients come back positive, then it's much, much harder to treat them. Will that be on your exam? No. But I want you to get an idea of how we're approaching this. All right, let's see what else is going on. Other ways, okay? Now that we diagnose the patient, now the question comes into place is, how do we treat the patient? Well, most surgeons, what they'll do it when you call a consult, and they said, this is going to be very easy. If you want to go and get ahead of the game, what we should do is this. Start the patient on just antibiotics, prophylactic. Put them on something that'll cover it. Bactrim, Doxy, Keflex, whatever. Just start them on the medication. The surgeon will say, not a problem. When I come in at like 9 o'clock tonight after I get done my rounds, when I come in, what I'm going to do is I'm going to take this patient to the operating. I'm going to cut the incision, I make an incision, get to the joint line, and whatever pus and all that bacteria is there, what we're going to do is we're going to do what? Debris it. Shoot some water in there and clean it all out. Now, whatever junk is already there, it's gone. Now, the chance of surviving, I'm sorry, let me rephrase that, not surviving, but getting this patient stable again becomes much, much higher because you cleaned out everything. Then, surgical debridement is done. Now, IV antibiotics to start. At this point, since when you went in there to do a surgical debridement, we took some of that gunk out and we sent it to the lab. The lab looks at it and says, oh, this is very simple. This is this organism. And we found out that it's sensitive or is resistant to this antibiotic. Does everybody understand that? Okay. For those who don't, I'll kind of take it backwards for a second. You can go ahead and take a sample of some kind of bacteria and you put it in a petri dish. And you take 15 petri dishes and you drop all the samples in all those dishes. The first dish, you'll put a penicillin in. Second one, you put a macrolide in. Third one, you put a quinolone. You get the idea? You put antibiotics in all of those. Put one little tablet in there. You let it cook. You come back the next morning, and what you should see is that tablet sitting right in the center, and then all the bacteria around it are crowded around that pill. That means that antibiotic is what? Resistant because all bacteria are around it. You get it. The concept is right. Okay? Then you move on to the next petri dish, and all of a sudden the tab is sitting in the center, and there's absolutely no bacteria around it in a nice radius. That will let us know that bacteria is killing everything around it. That means it's sensitive to it. Therefore, the report will come out and it'll say, you know what? Keflex is sensitive to that. We think that you should use Keflex to start this patient. And then you change the antibiotic, and then you bombard them with it. Get the idea? You can give IV, absolutely. Okay? But nowadays, there are certain medications that we know, like if you're covering MRSA, right? Then we know that Doxy works very well. We know Bactrim works very well. If it's just a simple cellulitis, then Keflex will work. But it depends. Okay? What's that? You could give Vanco, but Vanco might be a little overkill. Because Vanco is going to kill everything. It'll kill everything. Okay? But once again, you don't know. I've seen simple infections that are resistant to Vanco. You're starting to see it now. Years ago, it wasn't so the case. But now it is. Like, I'll give you a perfect example. I have this one patient who's a friend of some VIP patient. She's got chronic diarrhea. She's like in her 80s. We tried everything. Nothing works. The only thing that works for her is Vanco. Guess what? We put her on Vanco. She's on Vanco 24 hours. Every day she takes 6 pills of Vanco, which I think is absolutely crazy. The gastro said, listen, she's 80, if she wants to survive, that's the only thing that's gonna work for her. I said, okay, no problem. But you get the idea. That's how you build a resistance. Not good. All right, so once again, treatments usually go between 4 to 6 weeks. And the biggest problem is this. As we have mentioned before, this patient already has bacterial arthritis. That means it's going to go to other joint lines if it needs to. The one place it'll absolutely go to are joints that have what? Hardware in it. So if there's any kind of prosthetics in there, they need to be taken out. And the way it works is this. If you develop a really bad cellulitis here in your hip, on your right hip, and you also have a right knee replacement, you gotta be very careful. There's a chance it's gonna travel over there and it's gonna stay over there. They'll evaluate. If it gets to the knee, they go in there and take the hardware out. They put spacers in there, and then you sit in the hospital for 6 weeks until everything is gone, and then they put the they put the hardware back into your knee. So you're having surgery after surgery and surgery. Is that good? Not at all. Okay? No. Hey, you guys have an exam tomorrow? No? All right, let's move on to the second type of bacterial arthritis. Okay, that second type is gonococcal, meaning the bug that's involved here is gonorrhea. Now, the question comes into place is why gonorrhea? There's so many different types of bugs out there, Sam. Why are we talking about gonorrhea and only gonorrhea? Well, the reason why we're talking about gonorrhea is because this is a very popular bacterial agent that gets into joint lines. It's very popular, so therefore we have to mention it. Okay? There are other ones, but this one tends to be there a lot. All of a sudden, you get joint aspiration, you're sending it down to the lab, and the lab's like, yep, it's gonorrhea. It's gonorrhea, it's gonorrhea. You get it all the time. It's terrible. All right, so if that's all the case, let's kind of talk about it fairly quickly. We tend to see this type of arthritis in young, healthy male, females, sexually active. Once again, it's usually one joint. You tend to see it in wrists, elbows, it's everywhere. Once again, fever, same presentation as regular. But the question comes into place is, what's that? I understand, I paid attention to the slide before. How will I know if it's gonorrhea, if it's not? Aside from getting an aspiration, sending it to the lab, and the lab telling me it's gonorrhea. Is everything else the same? Yes, pretty much. But there are certain things that stand out, and the board's going to focus in on that. So one of the things that really stands out the minute you get gonococcal arthritis is this rash that presents. The small erythematous macule that turns into pustules. And you only see it in the hands and feet. Okay? If that's so the case, then you have to go ahead and do a full physical examination. You got to get cultures on pharyngeal cultures, GU cultures, and so forth and so forth. And once in a while, it has happened where you tend to see endocarditis and meningitis, but it's not seen so often. But what I really want you to do is pay attention to right here, because the boards might just tell you, hey, I have a 19-year-old male that comes in, or 23-year-old male comes in, having joint pain, right elbow, 3 days, blah, 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 blah. And then it's just going to say patient presents on a physical examination. They found the patient to have a small erythematous macule, papule rash that's only seen in the hands and feet. Oh, okay, that makes sense. That has to be gonococcal. What does it look like? It looks like this. Looks like that. What's that? I've seen it like 3 days, and sometimes you see it like a little bit longer. This is the exact same picture that was on my board. They still look fair and square. And here you guys have. So, how do you diagnose this? Once again, very simple. Physical examination, you see the hands and feet with this rash. All right, that might do it. If you want to get a confirmation, put a needle in there, aspirate some of that fluid out of there, and send it down. They'll tell you, oh, it's etiology is gonococcal. All right. We also know that blood cultures on gonococcal, they use about 13%. The question is, how septic is that patient? Once again, this is not going to be on your boards. This is not going to be on the examination, but if you do get a patient that you think that has it, has that presentation of the hands and feet on the rash, then that's fine. Then you have to do additional workup. So you might want to go ahead and get other cultures, rectal cultures, GU cultures, oral cultures, because they will come back positive for gonococcal also. You know, I'm onto something here. I got a rash, I got all the joint pain, I got the very unique rash that presents with it. Let me get some other cultures, see if they come back positive for gonorrhea. They probably will. And then, it's all right, well, maybe I get some ESR, CRP markers, some inflammatory markers to see if they come up or not. And then, well, can you get an x-ray? You could. If something's broken, you might see it. But it's useless to diagnose bacterial etiology. Can't do that. You can't look at an x-ray and say, oh yeah, I got gonorrhea. Can't do that. Makes no sense. Then, once you have all the data accumulated and say, yep, you got gonorrhea. Not only do you have gonorrhea, but it's also in your joints. Let's go and treat the patient. Well, we know that IV treatment is a drug of choice. The question comes into place is what? Well, the medication of choice is something called ceftriaxone or Rocephin, another name for it. 1 gram every 24 hours. But the problem is this has to continue. You have to keep on giving the antibiotics. Sometimes it's for 48 hours, sometimes for much longer. But what you should be doing, and the board's asked you to do, is once the cultures come back negative, then the patient can start on PO Rocephin or ceftriaxone and sent home. Only then can you obviously stabilize the situation. But the question comes into place: well, do you really stabilize the situation? No. Gonorrhea is a form of STD. Therefore, chlamydia, HIV testing, and syphilis, and so forth, they all have to be done. And then it goes even beyond that, because you're not treating one patient here. If you have a significant other and you have gonorrhea, then there's a good chance that your significant other has an STD also. So it's your job to go home and tell your significant other that, hey, I also have an STD, and I think you might have one too. Have fun doing that. That's probably the worst. Okay? So often that if you're treated with this at the hospital, they treat you no matter what. They say, nope, doesn't matter. You're getting treated. We're going to eradicate this. And then you go home and you have to tell your significant other. And then a social worker will call you and ask you and so forth. There's rules and regulations that, this involved. But you get the idea. Any questions on bacterial etiology, septic arthritis in general, and then more focused in on gonococcal? The only difference is identifying the organism. Once the organism is identified, only then can you treat it. And you treat it, treatment of choice is doxycycline. Not doxycycline, Rocephin and ceftriaxone. That is a drug of choice. But that's not to say that's the only thing. If the patient is allergic to it, then you can do quinolones like ciprofloxacin, levofloxacin, and so forth. Okay? The only thing that you have to be careful of is these 3rd and 4th generation cephalosporins are connected to what family? Penicillin family. So the patient has a very severe penicillin allergy, then pharmacy might say, well, listen, just be careful, because if you have a penicillin allergy, giving a cephalosporin might trigger that allergy, because they're kind of in the same family. So you have to be very, very careful. Somebody will say, well, what kind of allergy do you have? Do you have a simple hives and so forth? If that's all the case, not a problem. Still give the ceftriaxone, give them some Benadryl, or throw some prednisone on the inside. But if you have an anaphylactic reaction, that's usually a no-no. Yes.
So you said for ceftriaxone, you're going to continue giving it until the culture comes out negative?
Yes.
Even greater than 48 hours?
No, so you're going to give it until the cultures come back completely negative. And then you're going to give them oral and send them home on.
How
It depends. So mostly times it's between 7 to 10 days, and that's all. And then they have to follow up with the primary care doctor and get reevaluated. That's the reason why follow up with your doctors is key. And they always emphasize that you have to do that. And if you don't know, it's important for you to know. Once you leave the hospital, your first follow up with your primary care doctor, they really, really emphasize that, because that follow up from the hospital, the first visit with your primary care doctor, the primary care doctor builds a very unique code and they get paid more on it. So the doctors want you to come and see. Even though all the work is done at the hospital, it's a higher reimbursement. I'm not sure if that matters to you guys, but it's huge. Nobody cares, you guys are all gonna work for North Pole and half the service, so. Nothing's gonna happen, alright? Any questions on that? Anything? Alright. Let's move along. We spoke about bacterial etiologies. Let's move along to viral etiologies that cause joint pain. There's a few of them, but there's one that really is very common that we tend to see. Has anybody guys taken dermatology yet or not?
Yeah.
Okay, with Dr. Emmett, right?
Yeah.
Oh, I'm sorry, what did I say?
Dermatology.
No, forget about something. I meant
Yeah.
pediatrics with Dr. Emmett.
Yeah, we just learned.
I'm not saying dermatology is not important. I mean, everybody's going derm, right? Everybody's going derm. No, nobody's going derm. You know what's funny is you go back like 4 years ago and say, who wants to do something? I'm like, oh, I'm gonna go into ICU medicine. You go back a few years back then and like, what do you want to do? I'm gonna do orthopedics. Everything changes. The last couple of years, everybody wants to do derm. I don't know why. Like, I'm gonna go do Botox and fillers and shit. Okay. Go ahead. Just so you know, there's not that much money out there for those. You don't know, you'll think. You know, like what's portrayed out there, it's not all that glitters is in gold. Because people get Botox and like, oh, I'll go every 6 months. You're not gonna sustain a family on Botox for every 6 months, right? You need somebody who comes in like every 2 weeks. You need like people like on GLP, like they know the big weight loss, they come in every once in a week before 9 o'clock, they're lined up out the door. You give everybody injections and they come back every week. So if you want to build a business, you want repeat business, not every 6 months. There's no money in every 6 months. Unless you're in a home run, you get like, $50,000 from somebody, that's it. All right, anyhow, let's go back. Nobody cares about that stuff, but you should, that's really important. All right, let's talk about viral etiologies that cause joint pain. So one of the ones that really stands out is something called paravirus or paravirus B19, or another word for it is called slab cheeks disease. If you're sitting in this room, you might have gone up to it with Dr. Emmett. Okay?
Yes.
So let's do a little small refresher, and then we're going to talk about why it's so concerning for us in adults. In kids, it's cute, right? Because these kids come in and they're not feeling so well, they have a fever, and they're coughing, you have like flu-like symptoms and so forth. And we tend to see this between the late winters and spring. Okay? In kids, it's very easily characterized in the sense that not only do they have fever, sore throat, nausea, diarrhea, all the non-very specific symptoms, but the way it gives it away in kids is you have this erythematous, edematous plaques that start forming in the malar surface of their cheeks. And then non-facial rashes, same concept, you tend to start seeing them on their chest. And once again, it's cute because it looks like a slab cheek disease, meaning that the cheeks were slapped at, and therefore they get red and get puffy and so forth. We also know that it is a virus, which you guys should know already from Dr. Emmett, and you should know that any virus that you tend to encounter usually goes away between 7 and 10 days. In kids, everything seems to be okay because kids get fevers, they can sustain the fevers and so forth. And since it's the virus, it tends to go away. In kids, very easily picked up because of the rash. The problem comes into places when we start treating adults. Adults are not cute sitting in diapers. You don't look cute with slap cheek disease. It makes no sense. But the problem is, in adults, about 20% of them are completely asymptomatic, so you don't even know it's there. They don't get slap cheek disease. They don't get that kind of stuff. Instead, they get severe flu-like syndrome. So these patients will come in and the signs and symptoms will present like they're having the flu. So your job is going to be to differentiate between one and the other. The next question will come into place is the patient not only has severe flu-like syndrome or symptoms, but they're also having severe joint pain. Now you're going to say, well, I've seen patients who have flu, and I had the flu also a couple of times. I know there was kind of joint aches, but there was no severe joint pain. So therefore, it's probably not the flu. It can only be two other things. One, it could be paravirus, or what's another thing that causes really severe joint pain? Rheumatoid arthritis, but there's other symptoms for that, like dengue fever and things of that nature, right? Because it's a virus that we're talking about. So, all right, well, we're not going to talk about dengue fever because this patient's not traveling outside the country or anything like that. There's somebody that you know, no recent travel. So the case vignettes will focus in on that. No recent travel, so you're not thinking of anything else. You're thinking of somebody who has flu-like syndrome, but all of a sudden has real arthritic pain. Because in adults, 80% of them will have severe joint pain and flu-like syndrome. And you're gonna say, oh, I remember severe flu-like syndrome and joint pains. It could be paravirus. Okay? And we kind of move along. If that's so the case, then how do you treat this patient? Understand that it's a virus once you've kind of got a differential diagnosis. And then, most importantly, if you want to be a good test taker, then the answer option should help you figure out that question. You say, well, what do you want to give this guy? Well, NSAIDs. You know it's a virus. It will go ahead and self-limiting. It'll be gone within 7 to 10 days, maybe 14 days. Give him NSAIDs, bring down the inflammation, and we kind of move along. You get the idea? Okay. Question. Take a 5-minute break. We'll come back.
Oh, what lectures? My bad, little space. Anymore. Yeah.
Oh, now, oh, you're not sure of what's something. When you come back, I'll explain to you that it will come back open 25.
So then why did it say 24 to 40 hours on the board?
On the what?
On the side, like it's.
That's for just old school culture. I'm gonna talk about the new stuff and stuff.
Oh, okay, so if you guys know your culture right away, you can just, yeah, no timing, okay.
But it will come back. It usually takes a little bit long.
Wait, I have a question.
Yes.
Do we know, like, what the polar option?
I showed you a picture of what the negative ones, positive, and 10%.
Yeah, and what happened?
Okay, so I asked, I was like, please just move it to Wednesday. And they're like, are both not gonna be here. So I was like, can we get an alternative proctor? And we're like, oh, that could be very hard to organize. So this is to get the peds exam instead of, cause why is it there? It's a Monday. And we can always exams. We even have it schedule for 6.
Yeah, exactly.
I thought they were gonna. So. I'm saying. What about Tuesday? And Tuesday is just not possible.
Yeah, that's figured out.
What are they doing?
I don't know.
What?
I'll be third.
Tuesday is impossible. You have. Okay, I'm gonna try. I'll ask Dr. Brent. Here. But they're gonna be here.
Yeah.
They could definitely just come there. Look, they're like, okay, fine, we'll put it on the list to look into, so.
On the list.
We'll put it on the list. On the list.
We should find a proctor.
I think whenever.
What day is this?
That's great for it next, we're just like bring it on children like class, just randomly.
Do you wanna proctor us for a pizza exam? Yeah.
Why you guys are afraid of proctors?
No, we wanted the test for the.
Deirdre,
Later on that week.
Aaron are there, so back to back.
Have like a terrible exam.
You be there? Downstairs.
Yeah,
Like, I could find you like someone, like, I could add something.
Or Peter, or.
Yeah.
Josie, Josie. Perfect. Every time I told you, say, hey, where is Josie Walter Proctor?
You're on.
The middle of the.
No, it was.
They all are.
For every hour, and they're not gonna close that door.
You cut it.
And also if I'm watching.
I should be pausing this now?
No,
Are you proctor or Michael?
Oh, yeah, are you putting this,
Wednesday, that lab exam.
Oh, yeah, they asked me to, I think, Ali's not gonna be here, so I have to do like 3.
oh,
For 3 people.
Oh, that might be you. Oh, yeah, it might be our group. Oh. Yeah.
Yeah, that might be,
Yeah, you guys. You guys. It might be.
They still haven't.
I think but I don't know who's group it is. I think I probably somebody else's group, right?
No.
Doing pretty well, right? All right, let's get going.
Now, figure it out, guys.
I know.
Wait, did Sarah record a video of it? Yeah, she did. Can I get this? Okay. Yeah, I'll send it to you. Did they post the group?
All right, so, one of the students that came up to me and then actually made a great point, I should have mentioned this and I have completely slipped my mind. On the previous slide, it said that, hey, you run those antibiotics for like 24 hours, 48 hours and so forth. You could, sometimes you need it longer, but they'll constantly do cultures. They constantly do cultures, they constantly send cultures out. They'll just simply do blood work and they'll send that out to cultures and off we go. Some of you guys have been practicing medicine and said, well, cultures don't come back right away. Sometimes they take 3 days, sometimes they take 4 days and so forth. Both cultures come back. Yes, that's absolutely true. But other times, you might just treat the patient 48 hours because you sent in cultures and cultures all of a sudden completely negative. Your question might be, well, how do you get cultures back so quickly? Well, things have changed. Medicine has evolved. If you notice now, we have a lot of something called PCR tests that are done. PCR is simply a big machine that has every DNA coding for every virus that's out there, every bacterial agent that's out there. So the minute that blood comes in, they put in a specimen, they put it into the machine recognizes by looking at the DNA, and it tells you, yes, it's still gonorrhea. It still matches gonorrhea. It's still there, etc. You get lab results immediately nowadays with cultures. Back in the days, we put in petri dishes and so forth, and then we would see. If no gonorrhea is found within that sample, that means it's eradicated. Get the idea? So when you see those numbers out there only for 48 hours, at times you do see that, but it depends on where you're practicing medicine. If you're there and it's old school cultures for 3-4 days, cultures don't come back, that means that person stays on antibiotics for that. Get it? But you should know about new PCR testing. Everything's run by PCR testing. All right, let's move on to the next set of neuropathy that we'll speak about. And that is something called systemic lupus. This is a very popular neuropathy or disease process that we tend to see. And it's very complex in the sense that when you start looking at this, it also kind of overlaps with rheumatoid arthritis. Sometimes the treatments that we use are the same ones for rheumatoid arthritis, and sometimes even the symptoms are. So keep that in mind. Also keep in mind that when we go and test these patients, guess what? When we get a lupus panel, in the lupus panel, you automatically will also receive a rheumatoid panel in there, meaning RA and the complements that go with that. And if you go and testing for rheumatoid arthritis, guess what? You're also throwing lupus in there because they kind of overlap. So keep this in mind as we kind of move through this. Okay? So what is lupus? Well, we know it's an autoimmune disease, and it's characterized by exactly that. Autoantibodies that literally sit on your cells, and what they do is they actually think that the foreign invader is something else, but it's not. So it's constantly invading your own body. Because it's doing that, it causes significant damage throughout the body, and you can see it in every sense. In the kidneys, in the brain, and so forth and so forth. You will see parts of lupus hitting everywhere. Psychosis, neuro, etc. as we go through this. I'll point out what's really, really important, what you really should know for the boards and for the exams, and how they will present, and then some just for general knowledge. Now that you know a little bit about that, you have to know that the etiology, we have no clue what it is. If we did, we would get a much, much better understanding. But much of these neuropathies that fall into rheumatology are still unknown. We definitely know this, that if you have special antigens floating around the body like MHC, HLA, DR3 antigens, therefore, there is a genetic predisposition. If your mom has it, dad has it, there's a good chance that you will have it. Okay? or a higher chance, not definite, but there's a higher chance that you'll have. Now that we know there's a strong genetic component to this, question comes into place a little bit. Why? Do I really care about this? Yeah, you should, because you're gonna see a lot of patients that tend to have this. Before we move forward, just the physiology, the pathophysiology at the cellular level has to make sense. Because it's an autoimmune problem, then know that it's fighting itself for. So you'll start seeing these antibodies connected to the nucleus, the cytoplasm of the cell, to the heart of the cell, and it will alter it. And the one that you really need to know is, once again, is autoantibody, okay? Or anti-nuclear antibody, the most important one, and that is abbreviated as ANA. So every time you see someone having lupus, you should automatically think about ANA, this autonuclear antibody. That is key. Okay? All right, fine. I know the cellular level, that's what's going on. I understand that it's an autoimmune disease. I know it affects different systems in the body. Then fine. I know that's not going to be on the board, but tell me how the patient's going to present. Because it's all case vignettes. Fine. You have a patient that comes into your office. They might complain of some fever, fatigue, some weight loss, and joint pain. They can't figure out anything. Nothing. It could be a million things. As this case vignette progresses, it also tells you the patient is having some rashes that are exposed, patient having some photosensitivity. The patient goes on to indicate that every time he or she goes out to the sun and gets exposed to UV light, they develop this very unique rash. On the physical examination, the rash is defined as a butterfly rash. It's over the malar area. It's non-scarring. Kind of looks like psoriasis. You gotta say, oh, malar rash. Is it like slap cheek disease? No, because it's not a child. It's a full grown-up. It can be slap cheek disease. All right, is it painful? Yeah, it could be painful at times. Well, the only other rash that I noticed painful could be herpetic. But herpetic is not looking like a malopapular erythematous rash. All right, I'm getting confused here. I'll make it much more clear. This rash also spares the nasolabial folds. The minute you start seeing that, you're like, oh, psoriasis kind of looking like rash, sparing the nasolabial folds, and it looks like a butterfly rash around the face. Easy, ANA, lupus. We're moving along. Start figuring out the rest of the question. If that's not enough, if they don't give you this butterfly rash, then it might say, oh, this patient who has photosensitivity on a physical examination is found to have a thick adherent plaque rash. Significant scarring is seen. Where there's normally hair, there's alopecia. Okay. Significant scarring? Thick. All right. Don't see that too often. You know what? It might be lupus. I need a little bit more. No problem. Let's move on. Let's find some more. This is what the pictures look like. You see how this could really, really scar. This on the nose, and we're moving. All right. Anything else? Well, we said that it's a systemic problem. If that's so the case, is there anything that you want to present as far as system goes for the rest of the body? Because that might be in a case vignette for you to pull it all together. All right, well, let's talk about head, ears, nose, and throat. We know these patients tend to get ulcers, retinal vasculitis, cataracts, now big. Sjogren's syndrome. They will go ahead and throw that in their question. Patient also goes on and says that they're having some problems with the exocrine glands. They're having a hard time, constant dry eyes. They go to funeral, they can't cry. Saying they have a hard time with tear production. That might help. This is real. Some people just don't sweat. In South Korea, there's a big genetic component of patients having Sjogren's syndrome. In, I think, South Korea, they don't sell deodorant. Just not necessary. It's true. Look it up. I come to class, I think a few quarters back, and there was a student there from South Korea. He said, "Yeah, I don't smell." And they're like, "Get out of here!" Like, "Yeah, you come smell me. I don't smell. I don't know where to do." That wasn't a true story, but you'll remember that. You'll never forget that. That's the key for us. All right, let's move on. Cardiopulmonary. You might see some pericarditis. You might see some interstitial lung disease. Some myocarditis, rare, but it is there as we go through the symptoms. But what else is important? We said the rashes are key because you're going to see a lot of that. You might see a little bit of Sjogren's syndrome on board, but you will definitely see musculoskeletal issues for patient with with lupus, systemic lupus. What you're going to tend to see is things that overlap with rheumatoid arthritis, like your MCP joints or your PIP joints more. Most times they'll give you PIP joints because it mimics rheumatoid arthritis. Those are your Bouchard's nerves. And then one other thing that we spoke about, we said Jacob's neuropathy. We mentioned that in rheumatoid arthritis. So once again, A&A, the rashes, Sjogren's syndrome, and musculoskeletal, especially Jacob's neuropathy. Those are the 3 pointers that are really, really kind of stand out. And then you have other things, inflammation of the muscles, osteoporosis, you tend to see, yeah, baby. If you forgot what Jacob's neuropathy is, this is exactly what it looks like. And then, last thing that you tend to see, if it's a real medicine question, these patients have kidney issues. Not really AKI, but chronic kidney issues where it turns into a very serious thing. They have glomerulus lesions and leads to eventually kidney failure. Okay? Keep that in mind. So, kidneys usually tend to get involved, especially at a more chronic stage. Then, hematological reasons, you might see some anemia, leukopenia, and so forth. Not too much, nothing really to pay attention to there. Neurological disorders, we tend to see those. Sometimes CVAs, patients get too many strokes and stuff. We tend to see some kind of common denominator with systemic lupus, organic brain syndromes, headaches, and then this is something that you will see, especially if you do OBGYN. I'm not sure how many people are going to go into OBGYN here or not, but you will see a lot of this work on this antiphospholipid antibody syndrome and anti-neural antibodies. I'm going to leave this on the table for about 2 seconds until we go to like 2 or 3 more slides, and then I'll come back to this so you can understand, especially the females out there, especially people who are trying to get pregnant and constantly having loss of pregnancies and so forth. Okay, that is important, so you should know. Now, because that's going to affect everyone. The guys, you might have trying to have kids, and you guys can't get pregnant with you and your significant others, and that's something to kind of think in the back of your mind. All right. How do you diagnose this? Well, history and physical is key. Patient will come in complaining of joint pain and so forth. I'm having this rash on my face. You'll do the physical examination. You'll see it. You might see Jacob's neuropathy. You might see chronic dry eyes and so forth. You start putting everything together. Then you're gonna say, you know what? I think from the history that you give me and the physical examination that I've examined you on, I think you might have lupus. All right. Well, how are you gonna treat me? Well, before I treat you, I want to make sure I get a confirmation. I'm going to go and get some blood work on you, and I'm going to go and get something called ANA, anti-nuclear antibody. This will let me know that you can be positive for lupus. Alongside with that, there are more sensitive complements, C3 and C4. They will let you know if other organs are starting to get involved, like the kidneys and things of that nature. So when you get a rheumatoid panel, all that stuff will come in there. Alongside with that, ANA, C3, and C4 are automatically thrown in there. So important. Anything else? Well, that comes up to you. You can roughly decide that. If you think your patient has kidney issues from lupus, then you might want to get something called anti-dsDNA. If you think it's more musculoskeletal, Jacob's neuropathy, not too much else going on, mixed connective tissue disorder problem, you might want to get an anti-RNP. If you think it's Sjogren, fine, SSA, anti-SSB. Now, I'll kind of throw this out there. You can have Sjogren's syndrome and not have lupus. And you can have lupus including with Sjogren's syndrome. Does that make sense? Just like we were talking about other things. You might have Raynaud's phenomenon, but not have anything else. You can have that all alone. Same concept here. Okay, once again, the anti-phospholipid antibodies that are associated with systemic lupus, we find these in about 1/3 of the patients who have lupus, which is very high. Why do we always concentrate on that? Because it causes abnormal blood clotting. Patients who constantly get DVTs, high risk of MIs, and most importantly, pregnancy losses. God forbid, if you can't have a child or you have a hard time getting pregnant, you will go to a fertility specialist. And one of the first things that they'll do is they'll do blood work on you, and they will go ahead and get these anti-phospholipid antibodies. Okay? They will check to see if the component of the pregnancy loss is down to lupus. Now, some patients will present with everything. They'll present rash, Jacob's neuropathy, it's just a hot mess. Other times, it's very silent. You don't even know it's there. And you start seeing this stuff, this stuff, this stuff, this stuff. And then they'll start working you up. All right, other things. Once again, RF, rheumatoid factors positive, between about 20 and 30 of the patients who have lupus. And then there's all different kinds of reasons that can cause it. Secondary. You can have lupus by simply taking medications like minocycline. In the past, it's still kind of used, but in the past, if you go into dermatology, what do we use that for? What's that? Acne. In the past, we found out that certain dosages and how we treated patients who had acne, we put them into lupus state, and that was a problem. You're treating the acne, and all of a sudden they're getting other issues coming into place. Can't happen. Other times, psychosis. When you have psychiatric conditions, could be caused by systemic lupus, and on and on and on we go. Get the idea? All right. So, how do you diagnose this patient? Once again, ANAs, all these antibodies could be used, but you also want to get ESR levels, CRP levels to see how much inflammation you have in the body. You might want to get a urine to check to see if there's any blood or protein cast, especially if you have any kind of kidney involvement. And then, worst case scenario, if the kidneys are involved, you're not 100% sure, you send them to a nephrologist, and they might go ahead and do a 24-hour urine, or they might get a renal biopsy. Renals are what? Retroperitoneal. It doesn't take that much to go ahead and get a renal biopsy. You stick a nice thin little needle, go straight in there, grab from the kidney, and pop them out. It causes a lot of pain, but you can get what you want to get. All right. Treatment options, they vary. There's not one pill that makes everything go away. Doesn't exist. Question comes into place of what's the problem? If it's just a skin manifestation, then maybe some steroids will help. Okay? If it's a joint pain that's not getting any better, you give Plaquenil. It's an anti-malarial medication. You remember which fell in. It falls into the category of what? DMARDs, disease-modifying anti-rheumatic drugs, the ones that we spoke about in rheumatoid arthritis. Therefore, those medications will work. Joint pain, once again, NSAIDs, analgesics, anti-malarials. We find out that anti-malarial drugs that fall under DMARD tend to work very good with lupus medication. But that's not said you can't use the other ones. You could. Okay? Medications like methotrexate, which we spoke about, Cytoxan, they all work very well. But they have a lot of side effects, as we had mentioned before. So be very, very, very careful. Don't think that you're going to treat lupus with methotrexate, and then all of a sudden you got all these what? Methotrexate lungs with nodules everywhere and so forth. That is what you don't want. Okay? Patients who have just cutaneous problems, then you can go and give them what? Ask them to cover up, avoid the sun. That will simply do it. That's very easy to do, right? You get the idea. These patients, if the pain's really, really bad, then either they go to a nephrologist, they go to a rheumatologist, they're getting put on these DMARD medications, using malarial medications, that helps. If not, we can go ahead and give the other ones. Remember the ones that we spoke about? What are all the other medications aside from DMARDs? Anybody remember? There's a whole category of them. Infusions.
Where the money is.
Where the money is. Okay? Just that simple. All right, we're going to stop here, and we'll start on these spondyloneuropathies next time. We'll talk about all four of them. The next two classes We're gonna kind of go a little faster, if you guys don't mind, and we're gonna stick around